Let us now discuss the benign lesions of larynx. And the first disease that we have to discuss is the Rinke's edema. Now this disease we have already discussed earlier also. So as you remember, the vocal folds have 5 layers, and I showed you the hand model for the vocal folds. So what are the 5 layers of the vocal fold? Let's revise. Now the outermost layer was the epithelium. Which epithelium? Non-keratinizing stratified squamous epithelium. So I told you this is a different epithelium. So you see the thumb is in a different direction. This is a different epithelium than the whole other respiratory pathway, right? Then we have the lamina propria. A lamina propria had 3 layers: superficial, intermediate, and deep. And finally we had the vocalis muscle, right? Okay, now the superficial layer of lamina propria, it consists of loose areolar tissue, and that space is known as Rinke's space. So again, this is a potential space, the Rinke's space, and edema of this Rinke's space is known as Rinke's edema, right? So edema of Rinke's space is known as Rinke's edema, most commonly seen in chronic smokers. Okay, heavy smokers, we have the Rinke's edema, right? Okay, how will a patient of Rinke's edema present to us? A patient of Rinke's edema present to us with hoarseness of voice. So remember, any condition on the vocal folds, patient has hoarseness, right? Anything on the vocal folds, patient will always present with hoarseness of voice. All right. Okay. Now, what do we find on examination? On examination, you can see that bilateral vocal folds are in polypoidal condition. Okay. They are spindle shaped. They are become polypoidal like a polyp. So sometimes this is also known as smoker's polyp. This condition, Rinke's edema, may be known as smoker's polyp because these are polypoidal, floppy, or you can say spindle shaped. Okay. Now, what is the treatment of this Rinke's edema? Now, treatment number 1, of course, we have to stop the smoking. So, complete cessation, complete stoppage of smoking is the first step towards treatment, right? Now, if there is a mild Rinke's edema, it may subside on its own after cessation of smoking. But most of the cases do not have a relief. All right. So, then what we have to do? We have to finish this Rinke's edema, and that we do by stripping of vocal folds. Okay, so what we do is we do a stripping of the vocal folds. So we remove the epithelium from the vocal fold, and when we remove the epithelium, the Rinke's space automatically gets destroyed, right? So that is your stripping of vocal fold. Now remember one thing, when we strip the vocal fold, the epithelium on it will grow once again. So we'll have a healing of the vocal fold in some time. It will take a few weeks to a month time, and for that reason we will not do the stripping of both the vocal folds at the same time. Okay, so we do the stripping of one vocal fold, and after a few weeks, or let's say a few months, when the one fold has healed, then we will do the stripping of the other vocal fold. Otherwise, the raw area on the 2 vocal folds will lead to formation of a laryngeal web. All right, so we do stripping one after the other with a gap in between. Okay, let's come to the next condition. The next condition is known as vocal nodule, also known as singer's nodule or screamer's nodule. So this condition is generally seen in singers, screamers, teachers, hawkers. So what happens in them? In them, there is a chronic misuse of voice. Chronic misuse of voice. So patient speaks in a faulty way. So the patient shouts, okay, or patient tries to produce very, very high tone or very, very low tone. So what happens? There is an unusual strain on the vocal folds. You see, normally when you speak, the 2 vocal folds, they vibrate, they meet, they go away, like this. They vibrate, they meet, they go away. But if you speak in a very, very unnatural tone, now what will happen? These vocal folds, they start hitting each other. So when you shout too much, they start hitting each other, and this hitting each other leads to formation of these vocal nodules, right? Okay, so if you look at these vocal nodules are bilateral, right? So you can see they are bilateral. Usually they are symmetrical. So we have bilateral, we have symmetrical, and where are they? Okay, they are fixed. You see, these vocal folds, on them we have the vocal nodules, and these vocal nodules are fixed. That means they don't move. Where are they fixed? They are fixed to free margin of vocal fold. Okay, free margin. So they are not on the upper surface, they are not on the inferior surface, they are on the free margin, the margin that meet and hits each other. Okay, at the junction of, you see, at the junction of anterior 1/3 and posterior 2/3. Okay, at the junction of anterior 1/3 and posterior 2/3 of vocal fold. Now, why this particular place? Because this is the place for maximum vibration. This is the place for maximum vibration of vocal fold. Now, you will say the maximum vibration should be at the center. So remember, the posterior 1/3 is the, yes, is the vocal process of retinoid. Okay, the remaining is the vocal ligament, and it vibrates in its center. So you see the anterior 1/3, posterior 2/3 junction of the vocal folds, that becomes the most vibrating point for the vocal folds. Right, and there we have these vocal nodules. How will the patient present? Once again, the patient is having something on the vocal fold, so the patient presents with hoarseness of voice. Right? Okay. Now, what treatment will we offer? For the treatment, one thing we must remember, that these vocal nodules or the singer's nodule can be early or soft nodules, or they can be late or hard nodules. Okay, they can be early. Early means that they have yet not become undergone fibrosis, they have not yet become hard, and sometimes we have hard late nodules when the patient comes to us after some time. Okay, now when I was saying treatment, remember these patients, they have chronic misuse of voice. Okay, so that means if I do a surgery and remove them, these vocal nodules will recur because the patient misuse is not corrected. So my treatment is speech therapy. I have to correct this faulty speech. Okay, now these patients, it has also been found that all these patients, they have a lot of laryngopharyngeal reflux, and the laryngopharyngeal reflux is also thought to be causing or contributing to the development of vocal nodules. So, as a rule, we also give these patients proton pump inhibitors, PPIs, right? So, treatment of choice is speech therapy plus proton pump inhibitor. But, you see, this therapy is very good for patients with early nodules, with soft nodules. With these therapies, speech therapy and proton pump inhibitor, these vocal nodules will completely disappear. Okay, remember over here, vocal rest is different from speech therapy. Vocal rest means you ask the patient not to speak, or speak minimum for a certain period of time, 1 month, 2 months. But after that, if you don't correct the faulty way of speaking, the patient again shouts and screams. So the patient will again develop the vocal nodules. So vocal rest is different from speech therapy. Speech therapy, you train the patient to speak in the correct way. So that will prevent the formation of the vocal nodule. Okay, and it may even cause regression of early or soft nodules. But if the patient has hard nodules like this one, you may need to do a surgery. Okay, you may take up the patient for microlaryngeal surgery. However, in your exam, if the question is asked, treatment of choice for hard nodule, you will still mark your answer as speech therapy and proton pump inhibitors. Because this is the therapy that you will give. Only once the patient does not improve with this therapy, you will go for surgery. Surgery over here is adjunctive. Because even after surgery, you have to give speech therapy and PPI. So speech therapy and PPI is given before surgery and after surgery, and therefore that is the treatment of choice. Okay, surgery is done in only a very few selected patients who do not improved by this therapy. So that's just an adjunctive therapy to the speech therapy and proton pump inhibitors. Okay, let's come to the question, which of the following is true regarding Singer's nodule? Laser therapy is the treatment of choice. No, it is not. It occurs at the junction of anterior 1/3 and posterior 2/3. Yes, that's correct. Requires excision as it's potentially malignant. No, these have no malignant potential. Most common symptom is hoarseness and not pain. Okay, so answer is B. It occurs at the junction of anterior 1/3 and posterior 2/3. Okay, let's come to the next topic, that is the vocal polyp. So what do you see in the vocal polyp? Single, unilateral. Okay, it is single, unilateral, pedunculated. So as you see over here, this has a peduncle like a stalk. So it has a peduncle, it has a stalk. Now, because of this peduncle, it moves up and down with respiration. Okay, so like a flip-flop movement. So this one is mobile, right? This one is mobile. And where is it? Once again, it is at the junction of anterior 1/3 and posterior 2/3 of vocal fold. Okay, so anterior 1/3 and posterior 2/3 of vocal fold, we have this vocal polyp. Again, this is the place of maximum vibration of vocal fold. Okay, now why do we have a vocal polyp? A vocal polyp forms due to sudden vocal abuse. So if you shout too much suddenly, okay, suppose there are two people, now one of them shouts, screams on a regular basis. So what will this person develop? This person will develop vocal nodules, chronic misuse. Now, the two people have a fight. One of them is a chronic misuser of voice. The other one is a soft-spoken person. But this day, this person decides, okay, now I will also shout as much as the other person. So this person shouts. He is not a habitual abuser. He is not in a habit of using the voice so loud. But if this person shouts now, there is a sudden vocal abuse. Okay, and what happens because of this vocal abuse? Because of this vocal abuse, because of this sudden vibration, some of the capillaries on the vocal fold break. So the fluid comes out below the mucosa, okay, and then when you breathe, the negative pressure by the Bernoulli's phenomena that pulls this mucosa and the fluid with it to the airway and forms a polyp. Okay, so the vocal polyp forms due to sudden vocal abuse. How will this polyp present? This polyp, of course, it will present with hoarseness. Again, the patient has hoarseness of voice. Now you see, one of the fold is heavy and the other fold is light. So when they vibrate with different frequency. Okay, they vibrate with different frequency. So that means patient has diplophonia, double frequency voice. Okay, treatment. Now remember, the treatment for vocal polyp, the treatment of choice is microlaryngeal surgery. This polyp is formed due to sudden vocal abuse. Okay, the patient is a habitually soft-spoken person. All right, so there is no problem with his speech, so you don't need speech therapy. All you need to do is a microlaryngeal surgery. Right? Okay, so treatment of choice for vocal polyp is microlaryngeal surgery. Let's come to the next condition, laryngeal papilloma. Now the laryngeal papilloma is caused by human papillomavirus 6 and 11. Okay, remember 6 is more common and 11 is a more aggressive virus. So it causes a more aggressive disease. Okay, HPV 6 is more common, 11 is more aggressive. Okay, now the laryngeal papilloma, remember HPV virus, human papilloma virus, 16 and 18, they cause CS cervix. 6 and 11, they cause benign lesions. So laryngeal papilloma, this is a benign lesion. Okay, 16 and 18 causes malignancy such as CS cervix. Now this laryngeal papilloma can be of two types. It can be an adult papilloma or it can be a child or a juvenile papilloma. Let's first talk about an adult papilloma. The adult papilloma is generally a single papilloma. It is unilateral, of course, single and unilateral. It is a large papilloma. How will this patient present? It is generally on the vocal folds or nearby area. Patient presents with hoarseness of voice. Right? What treatment will you offer? You will offer is microlaryngeal surgery. Right? And the best thing about the adult papilloma is that the recurrence rate is low. So once you have treated this papilloma, usually it does not recur, so there is no problem with this papilloma. The main problem that we have is with the juvenile papilloma, okay, and we call it as juvenile onset recurrent respiratory papilloma, JORRP. Now this is the one which is important. So this papilloma happens in children, right? Okay, now children, which age group? The usual presentation is at the age group of 3 to 4 years. Okay, now how does a child acquires the papilloma virus? Now the child acquires the papilloma virus from the mother. Okay, how? See, the papilloma virus lives in the genital tract. So the child acquires the papilloma virus during birth. Okay, so during birth means during normal vaginal delivery. So, and in this normal vaginal delivery, the child passes through the vaginal tract. So therefore, the child acquires the papilloma virus at this time. Now, the chances of acquiring the virus is more common in case of firstborn child, primi gravida. Why? Why in primi gravida? Because in primi gravida, in the firstborn child, the vaginal tract is very narrow. Okay, now in a multipara female, this tract opens up. So in the firstborn child, it takes more time for the child to go through this tract. It spends more time in this vaginal tract, and therefore the chances of acquiring the virus is more in the firstborn child. Okay, right? A child born to a primi gravida mother, right? Okay, so the virus is acquired in the genital tract, more common in the first child. How will this virus present? It can present, this papilloma can present with hoarseness, okay, or it can even present with stridor, respiratory obstruction. Okay, these papillomas, they are multiple. As you can see in the photograph, they are multiple, they are bilateral, they are small. Okay, sometimes they may grow big and they can cause respiratory obstruction also, but usually they are multiple, bilateral, small. Okay, and they are believed to be arising at the junction of the epithelium. So which junction? You know, we have the pseudostratified ciliated columnar epithelium in the respiratory pathway, and at the vocal folds we have the stratified squamous epithelium. So at the junction, superior arcuate line and inferior arcuate line. Okay, so at that junction we have the formation of these papillomas. Okay, now the major problem with this papilloma is that there is a very, very high rate of recurrence. Okay, there is a very, very high rate of recurrence in these papillomas. So that is why the name recurrent respiratory papillomas. Okay, now suppose a patient comes to you. What will you do for this patient? Okay, so number one thing, if the patient is having respiratory obstruction, you may like to do a tracheostomy. Okay, now over here, first thing, the tracheostomy is relatively contraindicated. There is a relative contraindication. It's not an absolute contraindication, but papilloma is a relative contraindication to tracheostomy. Why? Why? You see, I told you the papilloma arises at the junction of epithelium. So the junction we have on the vocal fold, superior arcuate line, inferior arcuate line. If you do a tracheostomy, you are making an opening into the trachea directly from the skin. Now the skin has keratinizing stratified squamous epithelium. The trachea has respiratory epithelium, pseudostratified ciliated columnar epithelium. So this tracheostomy creates a new junction. It creates a new junction of the epitheliums, and the virus may go down and there may formation of papilloma at this tracheostomy site also. Now this is dangerous. Why? Because we have the next junction at the bronchi and the alveoli. The bronchi have the pseudostratified ciliated columnar epithelium, whereas the alveoli have the squamous epithelium. Okay, so this papilloma may even spread into the lungs, into the alveoli, where there may be formation of new papillomas at the junction, and that can be really life dangerous. Okay, it can be life threatening disease. All right, so we try to avoid tracheostomy as much as possible in these patients. Patient has hoarseness, there is no blockage of the airway, so you would not like to do tracheostomy. If you do tracheostomy, you would like to do tracheostomy as far away from the larynx as possible. So we do a low tracheostomy. Okay, that means you make an opening between the third and the fourth tracheal ring. You do a low tracheostomy in these patients. All right, now how will we treat this papillomas? The treatment is surgical excision. We have to remove the papilloma, so we will do a surgical excision. So now the question is, how will you do a surgical excision? Now the earliest method was cold steel instruments. Okay, now when you do a cold steel instruments, the problem with the cold steel is that there is a lot of bleeding. Okay, and when there is a lot of bleeding, it leads to incomplete excision. Right, you are not able to remove the whole papilloma, and it will lead to lot of scarring. So the voice will become bad. Okay, and it will also lead to a very high rate of recurrence. Okay, so this cold steel excision is not preferred nowadays. Okay, because of high rate of recurrence, some patients may even have to undergo excision every month. So patient may be having a GS surgery every month. You can imagine in 10 years he may be having 120 surgeries. So that is a very, very bad situation for the patient. His quality of life is totally degraded. Okay, now therefore some other methods of excision were tried, such as laser excision, carbon dioxide laser excision. Now carbon dioxide laser excision is very good as per se the recurrence rate, because you get a bloodless field. Okay, so you are able to remove almost whole of the papilloma, and therefore the recurrence rate is low. But the problem with the CO2 laser excision is the fumes. The smoke fumes created by this carbon dioxide laser excision. You see, these smoke fumes, they have the papilloma virus, and it has been proven that this papilloma virus in these smoke fumes can spread to the operating surgeon as well as the OT staff, and then they can have the papilloma. So these smoke fumes, they are contagious. They have the papilloma virus. In fact, this has happened with a surgeon, and then the genome of the surgeon's papilloma was matched with the patient, and it was found to be same. So the papilloma from the patient spread to the surgeon because of the carbon dioxide laser excision. So this is no longer preferred. Okay, so what do we do these days? We do microdebrider excision. Now this microdebrider has a cutting blade with a suction inside it. So whatever it cuts, it sucks inside. So papilloma as well as the blood, everything goes inside. You have a clear field, and therefore you are able to do a complete excision. Okay, so this leads to lesser rate of recurrence without causing any danger to the operating team. So this is the current treatment of choice, microdebrider assisted excision of the papilloma. Right? Okay, now to decrease the rate of recurrence, we also have medical therapy. Right? This medical therapy in papilloma is basically adjunctive therapy. Okay, it is basically a adjunctive therapy. It is to assist the surgical excision to prevent the recurrence. Right? Now, for medical therapy, we have three lines of thought. Number one, we can give a antiviral drug. It's a viral infection, we can give an antiviral drug. Number two, we can give a anti-proliferative drug. So that will decrease the formation of the papillomas. And number three, we can give a immunomodulatory drug that will increase the immune response toward the papilloma virus or the cells which are having the papilloma virus. Right? Now, the drug that is very commonly used and asked in the exam is interferon alpha. It has all the three properties. Okay, this interferon alpha is antiviral, it has anti-proliferative action, and it has some immunomodulatory action also. So this is one of the drug which is used for the treatment of or for preventing the recurrence of JORRP. Other than interferon alpha, we also use drugs such as bevacizumab. Now, bevacizumab is a recombinant antibody drug and it prevents angiogenesis. So it has anti-proliferative action. Okay, then we have other drugs such as cidofovir. Okay, now this cidofovir is a antiviral drug. Okay, right? And then we also have ribavirin. It is also antiviral drug. Okay, the cidofovir is to be injected intralesional. Right? So remember, the cidofovir is injected intralesional, whereas the ribavirin can be given as a aerosol spray. So patient can inhale it or put as a spray, and it can go into the airway, into the larynx, and cause a antiviral action. Okay, so cidofovir has to be injected inside the papilloma. Now, other than that, we can also use antiviral drugs such as acyclovir. We can use drugs such as cimetidine. So there are different drugs which are used, okay, for treatment of these. Drugs have been tried, antiviral drugs, to decrease the recurrence of the JORRP. The important drug that you have to remember is the interferon alpha, the bevacizumab, and cidofovir and ribavirin. Okay, now there is one more therapy which is being recently used, and you have to remember, is the photodynamic therapy. Okay, now what is this photodynamic therapy? In the photodynamic therapy, in this therapy, you give a agent which is an inert agent, so it has no action, okay, such as dihematoporphyrin ether. Okay, we call it as DHE, dihematoporphyrin ether, DHE. Now, this is an inert agent, and this inert agent is given to the patient. Now, this agent, it accumulates in the papilloma cells, right? So this accumulates in the papilloma cells. So now we know that the major cause of recurrence is basically the hidden virus in those cells which have yet not become papillomatous. So those are papilloma cells, those are cells having the papilloma virus, but surgically when we look at them, they appear to be fine. So it accumulates in all those cells which have the papilloma virus. And now what we do, we go and do a surgery, such as a microdebriderasis surgery. So we have removed the maximum papilloma. Okay, and after we have done the surgery, we give a particular wavelength of light, such as we give 50 joules of 630 nanometer of argon laser light. Okay, so we give argon laser light 630 nanometer. Now what happens? This activates this DHE. Now the DHE is activated. It becomes a toxic drug, right? Now remember, so when you shine this particular 630 nanometers of argon light. Now what happens? This converts this inert agent into a toxic drug. And remember, it was accumulated in only those cells which had the papillomavirus. So it killed those cells, and therefore the recurrence goes down. Right? So this is the photodynamic therapy which is being utilized these days, and it is now being also tried to attach to a recombinant antibody so that the drug is directly delivered to only those cells which have the papillomavirus. So this photodynamic therapy is something latest, and this can be asked in your exams, especially the INI CET exams. All right. Remember, a lot of research is going on these papilloma viruses and the JORRP. Okay. In fact, one of the therapy that is recently being used is the zinc therapy. It has been found that the patients who have the recurrence, who have a lot of recurrence of JORRP, in them the zinc deficiency is seen. So the zinc therapy is given to prevent the recurrence of JORRP. Per se, the zinc may not be having antiviral action, but it has a immunomodulatory action and is basically used to decrease the recurrence of JORP, because all these patients have been found to have a zinc deficiency. Okay, let's look at this question. Juvenile recurrent laryngeal papillomatosis is caused by which virus? And answer is HPV virus. Okay, next question. A 2-month-old child. So 2-month-old child who was born by normal delivery. You see, normal delivery to a primigravida lady, presented with below hoarseness and finding on laryngoscopy. So what do you see on laryngoscopy? You can see multiple papillomas in the larynx. What could be the possible diagnosis? So all the hints are given to you. A very nice image is given to you. This is a case of recurrent laryngeal papillomatosis. Right? So very straightforward question, clinical question, but very straightforward with all the hints in the question. Next question, which was asked in the exam, all are done for recurrent laryngeal papillomatosis except zinc therapy. I just taught you that we do give zinc to prevent the recurrence because these patients who are having recurrence have been found to have zinc deficiency. Intralesional cidofovir, yes, we give intralesional cidofovir. You can also give aerosol ribavirin, and then we also give interferon alpha. It has all the three functions: antiviral, anti-inflammatory, or you can say immunomodulatory, and it also has the effect of anti-proliferative action. Steroids, however, is not used. Right? Okay. So answer is steroid. This is not done. All are done except was the question. So answer is therefore steroids. All right. Now, before we finish the topic of JORRP, just remember that sometimes this JORRP, because of repeated surgery, repeated scarring, okay, multiple recurrences, this can even convert into squamous cell carcinoma. So there has been a chances, there have been incidences where the JORRP, inside the JORRP, there is development of squamous cell carcinoma. And as I told you that this JORRP can even spread to lungs. So if the patient has lung squamous cell carcinoma, the prognosis becomes extremely bad. Right? Okay, let's come to the last benign disease that we have to discuss. This is the vocal cyst. Okay, so there is formation of a cystic lesion in the vocal folds. The reason can be multiple, such as a misuse of voice, or there is a trauma to the vocal folds, and because of that there is collection of a mucoid secretions below the mucosa leading to formation of a cyst. Okay, how will the patient present? Patient presents with hoarseness of voice. Right? On examination, we can see over here that there is a cystic lesion on one of the vocal folds. It is pressing, and therefore the other vocal fold is also affected due to the press of this vocal cyst. Remember, this cyst, what appears as a cyst may even be a lipoma. Okay, both of them have an extremely same appearance, same presentation, and the same treatment, that is the microlaryngeal surgery. Only on surgery we can differentiate whether that's a cystic lesion or it is a case of a lipoma. All right. So both of them have the same appearance, same presentation. treatment is also same, that is the microlaryngeal surgery, and we excise this cyst or the lipoma.